From 12 News, this is Newsmakers.
Hospitals not only play a critical role in caring for the region's sick and injured, they also represent the largest employers in Rhode Island. So their health is critical to the future of the Ocean State and beyond. What is the state of play for the largest hospital groups, and what needs to change in the state's healthcare ecosystem to ensure their long-term viability? We ask our guests this week on Newsmakers, Dr. Michael Wagner, President and CEO of Care New England, and John Fernandez, President and CEO of Brown Health. Welcome to Newsmakers. I'm Tim White alongside 12 News Politics editor Ted Nesi, Dr. Michael Wagner from Care New England, and John Fernandez from Brown University Health. Good to have you both on the program. Thanks for joining us.
Glad to be here.
A lot to talk about, but I want to start here. I can remember a time not too long ago where it would have been very difficult to get the leadership from then Lifespan, now Brown Health, and Care New England to sit together on this set on this show. Besides leadership, what has changed? John.
I like Mike.
And similarly, I like John as well. I think the key issue for us has been, I think we both came in, at least our board, very clear about we want to chart a path forward as an independent organization. We have a relationship with Brown Health, Lifespan at the time. How do we take advantage of the opportunity for us to work together? And then when John came on board and got the job, literally like the two of us within months of each other, I was very happy because John and I worked together in Boston, and it developed a very good working relationship through the Council of Boston Teaching Hospitals. So for me, it was a really great opportunity for us to reset the relationship.
And of course, you two both have mutual interest in what we want to talk a lot about, which is Medicaid and Medicaid reimbursements. You both penned an op-ed in the Providence Business News imploring the state to invest more in Medicaid, which is the public insurer for low-income patients. Rhode Island has a high percentage of Medicaid patients, but the state has some of the lowest reimbursement rates in the region. All right, so the Hospital Association of Rhode Island was not pleased with the governor's budget in that regard. John, have you talked to him about it? Have you sent the governor a letter? Have you tried to communicate with the governor's office?
Definitely communicated, did not send a letter. So as Mike, we've done it together. We went to went to see the governor before the budget came out. We keep in close touch, but unfortunately the budget came out not how we would like it.
Well, I'll tell you, Mike, John, we'll stick with you on this first. So what the governor's team said to us at the budget briefing, Tim and I were both there, was, hey, times are tight, state revenue's going up 2.5%, I believe that was the number, and we're going to give the hospitals what the state is getting. And that they just need to accept that. Why isn't that acceptable to all of you?
Well, they gave us a tax increase and reduced our reimbursement where we need an increase. Medicaid, just remember, Medicaid is the insurance company for the state. They decide what we get paid. And they're deciding not to pay us for the services we render and pay way under the other states and way under Medicare and way under commercial. So they are deciding how much we get paid. And we just can't keep it up. And what we have done is proposed how could we get better payment by using matching funds from the federal government. The other fact with Medicaid is over the last 5 years, the state has decreased the state commitment. The number has gone up because of more federal matching, which was led by the Hospital Association to get more funding from the federal government. And now we want to try that again.
And I do just want to remind people, because I think people can forget that Medicaid, next year's budget, it's almost $5 billion. It's over a third of the entire state budget now. Yeah. It's just a huge, huge program. Mike, for Care New England, I think of women and infants, and I think of births, because I think, is it a majority of births in Rhode Island are Medicaid funded now?
About 50% of the births at women and infants.
Still a lot.
It's still a lot. It's huge.
So what would the effect, particularly on your organization, zeroing in on Care New England, be if the current Medicaid proposal goes through? The governor's, that is.
So the overall, a $25 million reduction in reimbursement for the state as a whole in terms of healthcare providers. And for us, it would mean less reimbursement on those births and on the other care that we provide. About a third of the population in Rhode Island is on Medicaid. So it's a huge impact if we see a further reduction. I think when we look at the Medicaid program, there are very few ways to bring more dollars into the state to help healthcare. Our healthcare organizations are in a state of crisis. We have a primary care crisis. We have an issue in terms of deferred capital investments. Our organizations are old and they need to be refreshed. We would argue that more dollars need to go into healthcare, into physicians, into the organizations to help create the right environment. There are very few ways to do that. One is to ask people to pay more, businesses to pay more, or look for alternative sources, i.e. Medicaid, that actually by investing one more dollar, we can bring in dollars from out of state through the federal match program into the state. So it's actually one of the few ways that the state can make an investment that actually multiplies an investment back into healthcare delivery in the state.
So there are still ways the hospital leadership thinks that the state, because I know I've covered this a long time, there's always different ways to change how you do it at the state level, so the federal match goes up, et cetera, but you all think there's real money to be found by changing that further.
Correct.
Absolutely. We actually just did it 2 years ago.
Yeah.
We just didn't maximize it for whatever reasons. We weren't here. But if we put in 90, we're going to get 270. That's real money for the state of Rhode Island. That's for Medicaid. That's for the poorest people getting health care. And it helps the state, helps jobs. And the state just has to help. We have to find a way to work with them to find the $90 million. Or look, if it's a little less, it's a matching program. There are very few investments I know that you can get at 2 to 1. Or 3.5, 3 to 1. I'd do that. If I could invest my own money in that, I'd do that.
So you didn't have much luck with the governor in lobbying him. The budget's now with the General Assembly.
Yeah.
Have you met with Speaker Shekarchi?
Absolutely.
All right. What kind of feedback are you getting, and are you optimistic or feeling grim?
So first, the speaker has been awesome. If you were at the chamber event the other day, he has our message clear. He can repeat it frontwards and backwards. His only thing is, where am I going to find the $90 million? But he is hopeful, come the spring when the revenue comes out, if there's money, that he would then be able to help us find that $90 million. And we'll give him some advice on where to find the $90 million.
Well, one way to find $90 million is something lawmakers don't like to do: raise taxes. Are we at that point, Dr. Wagner, where you think the lawmakers should be considering that?
No. Quick answer, no. I don't think we should be looking at increasing taxes. I think we should be looking first at the issues we're talking about. The question of, are there other dollars in the state budget that could be cut or looked at differently? I think we would like an open conversation about our ideas about what could be done there.
The context as we talk about this, of course, is that there's also federal Medicaid changes, potentially big Medicaid changes coming. So we're talking about, well, if we up this, I'm listening to Republicans in the House of Representatives say, we want to stop the states from what they are arguing are games with some of these Medicaid matching dollars, provider taxes, things like that. What is the interplay between these two? I'll stick with you first, Dr. Wagner, of watching the potential cuts to Medicaid coming from the feds while you're telling state leaders we need you to get more money out of them through the state budget.
So first of all, the mechanism we're proposing is a well worked out mechanism. It's currently in place, and both blue and red states are using the mechanism. So that's an important part to start with. Secondly, is we don't know what is going to ultimately happen with regard to the changes. And there's a lot of different ways the Medicaid program can be modified. We don't know what it's going to look like. So we've stuck, and this has been a hospital association agreement around, we need to stick with the plan, because the current proposal uses existing mechanisms, and we should take advantage of that. Otherwise, we've been negotiating against ourselves, because we actually don't know what might actually happen. So we're going to stick with the plan.
And what I would say is, if we don't ask, we sure won't get it.
Yeah.
And so whatever might happen or might not happen, it's a great deflection strategy, like having the state reps going, well, Washington won't approve it. Well, if you don't ask them, they can't approve it. So why don't we get our state business in order, then make the ask. If the federal government says no or cuts the program, then we still have a problem. I mean, I think people can't forget the problem will exist, and we'll have to find another way to do it, which is commercial rates, more money out of the state. Hospitals, physician groups, community health centers. In my 2 years here, I could rattle off at least a handful of near or going into bankruptcy. Not having a bad time, not having a bad year, bankruptcy. And that is not going to serve the people of Rhode Island well.
All right, we got to take a break here on Newsmakers. When we come back, it's no surprise to you, it's really hard to find a doctor right now. What can be done? Stay with us. You're watching Newsmakers. Welcome back to Newsmakers. I'm Tim White. This is Ted Nesi. Our guest this week are John Fernandez. He's president and CEO of Brown University Health, and the president and CEO of Care New England, Dr. Michael Wagner. Gentlemen, our colleague Alexandra Leslie had a special report last month on just how hard it is to get a primary care physician in this state. I suspect you would both point back to the reimbursement rates that we discussed in the first part of the program. But Dr. Wagner is an internist, right? Yep. I wonder if another big factor is that more doctors just want to specialize because it's more lucrative to them.
Yeah. True. We've seen a decrease in the number of students going into primary care specialties, and internal medicine, very few graduates stay in primary care internal medicine. The good part is that in this state we have a family medicine training program, which actually is nationally recognized and is one of the sources of being able to recruit doctors in the state, primary care. But you're right. The reason why we have a primary care crisis, we talk about, is healthcare in crisis? Ask anyone, can they find a primary care doctor? Right. Did they lose their doctor? The answer is yes. That's a crisis today. The reason why that's the case is very much around reimbursement. Increasingly, because of reimbursement, it's harder for practices to stay independent. And evidence of a healthy ecosystem in primary care is the ability for doctors to stay in private practice. We provide, between our two organizations, the hospitals and the federally qualified health centers, a huge amount of the structure for employing primary care doctors. The average support per primary care doctor is somewhere in the range of $150,000 to $180,000 a year. So we have to support that cross support because inadequately we are reimbursing primary care.
I want to ask you both about your corporations, the two enterprises, Brown Health and Lifespan. I'll start with you, John. It's been a very interesting year for Brown Health. I've been covering Lifespan was covering you all for a long time. You have the new name and the new expanded partnership with Brown. As always, I do like to remind people, Brown didn't buy Lifespan. It's a marketing agreement, and there's all this tied together stuff you can read about online. But you also just expanded in a big way into Massachusetts by taking over St. Anne's and Fall River. I was there with you and Governor Healy when you announced that, as well as Morton and Taunton. I'm just curious how that Massachusetts acquisition has gone so far. These were some of the steward hospitals that were so troubled.
It's gone very well. It's hard work, though. We're putting in a new computer. We're putting in Epic in there, getting them on our systems. There's a lot of work, and the staff, the nurses, doctors, the leadership there have been working really hard. So it's hard work, but thankfully no horrible surprises.
I do think, too, people in Rhode Island, I kept seeing from viewers when I would report on that, they'd say, well, wait a minute, is our Rhode Island money that we're already saying there's not enough of getting piped over into Fall River and Taunton? I understand that that's not, but can you, in sort of layman's terms, explain why you think this is actually good for the Rhode Island side of Brown Health?
So it's good for Rhode Island because it'll help us financially in the long run. There's also 30,000 patients that were coming from Massachusetts. Now they can stay closer to home. It will give other options for ambulatory surgery just over the border for people that have insurance that can be in Massachusetts. So better access. It'll help us financially in the long run. We had to figure out a way to diversify our revenues. That's part of our four-part strategy. So that's how it should help in Rhode Island.
Just if I can do Care New England, Mike, you're in a different position. I mean, and as you said, you both came in at the same time as both organizations were kind of at pivot points when the merger fell apart under the prior leadership. Care New England feels a little, Brown Health has to go on and be the big dog and do kind of what Lifespan's always done on some level. You're big, but not the biggest.
Right.
Could you see yourself, buying like Roger Williams or Fatima to get a little bigger on the Care New England side? Is it not about expanding the size of Care New England for you? So
for us, it's very much around the foundation of healthcare delivery, primary care, women's health care, pregnancy, newborn care, behavioral health. Those are our areas of strength. We believe, and there's less and less reliance on inpatient care and more on ambulatory care. So our focus has really been around foundational aspects of healthcare delivery and ambulatory care, which is why we have the hospital at home program through Kent. We're building ambulatory access points. We have an ambulatory surgery center that's going to be be built in Providence. more of an ambulatory strategy and a foundational aspect. Our focus is on Rhode Island, and I appreciate my colleagues moving into Massachusetts, but there's a lot of work that has to happen foundationally in Rhode Island, and we see Care New England being part of that solution.
Brief follow-up on that. Can Care New England survive as roughly the size it is now, independent, or are you inevitably at some point either getting gobbled up by Mass General, Brigham or Yale New Haven?
So I would argue that we will never need to be gobbled up. I think that what long-term is that as a foundational healthcare system in Rhode Island, regardless of whatever affiliations we have in the future, we'll be playing an important role in terms of providing that foundational aspects of care. That, I believe, is sustainable in the long term.
All right,
we have to pivot.
I apologize. Why don't we take a break here on Newsmakers? We'll wrap up our conversation with the heads of the 2 largest hospital groups in Rhode Island. Stay with us. You're watching Newsmakers. Welcome back to Newsmakers. I'm Tim White. This is Ted Nesi, and our guest this week, John Fernandez from Brown University Health, Dr. Michael Wagner from Care New England. So here's a medical term I did not know until recently, which I think speaks to the problem, which is boarding. This is when a patient is kept overnight or even days in an emergency room rather than transferring them to inpatient beds. Look, anecdotally, based on what we're hearing into the newsroom, this has been happening more and more, particularly at Rhode Island Hospital. You know, is it that there aren't enough beds to put these patients, or is there not enough staff for those beds? Why is and you can dispute that boarding isn't an issue right now.
It's an issue.
Okay, good.
Keep going.
So what's the problem?
Not a
What's
medical
going on?
term. It is the problem mostly is staffing, but not in the emergency department. Sometimes it's the emergency department, but the real problem is an engineering one, which is we don't have enough staff in some of the units in our inpatient. Patient can't get up into those beds. They sit in the emergency department. There's also
in the hall.
Or
right?
in the hall. I mean, it's bad, and we are doing everything we can, every trick you can think of to try to fix that. But it is this, and lots of patients coming into our emergency departments. So it's also how can we get some of those patients not to even come to the emergency department, and also this sort of social network of where could we send that patient to home or to drug and alcohol, substance abuse place. There just isn't a lot. So guess where they come, or mental health facilities.
Yeah.
We don't have a lot of those. So they sit in our ER waiting for a bed.
I wonder if that goes back to our conversation about the lack of primary care physicians in the state, and so people can't get a doctor. They go to the emergency department.
Well, certainly it will get worse if we have a worsening in primary care. The ED backup will get worse because more people will seek care in the emergency room or in urgent care centers. Well, on behavioral health side, so there's both the med-surg border and then there's the behavioral health border, the person who needs acute psychiatric care. We recently added a short stay unit at Butler, 25 beds, that helped to alleviate the boarding issue and specifically designed to work with the ERs across the U.S., the state, in terms of helping to identify patients and getting them out of their ERs to Butler, and then we can triage them from there. So we are making some progress. Also the movement to the community behavioral health center model that the governor has put forward and is actually a really good improvement that's having an impact. We're seeing some early impact of that as well on the behavioral health borders to try to prevent them from having to go to
it's just real interesting. I'm sorry, Ted, I'll wrap it up, but I went into this thinking, well, there's a lot of boarding because it's been an awful COVID season, awful flu season, RSV season. What I'm hearing is it's more about mental health, folks with mental health issues walking into the ED.
Mental health and the med-surg patients, same issue. But you don't have enough staff, and part of the staffing is paying people. That's part of our rates are lower than they are in Massachusetts, and that's because we're getting low rates. We have a crisis. People go over the border. They retire early. A small change in nursing means in a 24/7 operation means you can't run that bed for that day. And then one bed leads to somebody sitting in the ER and it backs up, whether it's psychiatric care or just general med surg. And the flu season, you do hear it's worse during flu season because more people come.
Patients.
Of course.
Isn't fundamentally the problem here that Rhode Island is just significantly poorer than Massachusetts and Connecticut, yet in a way is in a regional market for workers and healthcare and everything. And there's just not enough money sloshing around Rhode Island to fund healthcare seemingly at the degree that's needed. I mean, I go back, the state budget's not big enough to provide the infusion necessary that you guys think.
All the more reason why we should be pushing on the Medicaid matching funds. It's the one way to bring more dollars into the state, for the exact reason you've just laid out.
Because if we don't do that, then it's commercial rates. Probably not going to affect Medicare, especially at this moment.
Right.
But that's bringing money that other states, it's been done in Kentucky, Oklahoma, all of our neighboring states did this years ago. So I think part of it is on us as a state. We didn't pull all the levers that we needed to pull. Now we need to pull them.
John, let me stick with you in a quick one, which is last night, we're talking about not enough money. Last night they were talking about getting money out of you at the Providence City Council, which is, as the city's facing a financial issue because of their school funding increase. Alexandra Lissa has a story on our website right now about that. As always, there's talk of reopening pilot agreements, the payment in lieu of taxes, and there's a particular frustration on the council, it sounds like, with the size of the Brown Health reimbursement. What is your message to those councilors who are saying to the mayor, go back to Fernandez and get more money out of him?
No thanks, we're in crisis. But we worked out a deal with the mayor and the council that they approved, and we'll live by it. We're also relocating some of our real estate right in downtown that I think is showing our commitment to the city of Providence.
How about Care New England? Any money can come out of you guys? Or how long is your pilot left?
We are coming up to our negotiations. So,
what's your message going to be?
We will negotiate and continue. We've been actually very.
You're not going to Newsmakers.
Yeah, I'm not. Yeah. I'm going to tell you exactly. Mayor Smiley, right here on Newsmakers.
All right, we have about a minute left. Lawmakers, including the Senate president, have discussed opening a medical school at URI. I don't think you guys are on the study commission, right, for that?
No.
Okay. No. It would have a focus on encouraging medical students to stay after they leave college. Like 45 seconds here. Something you support, John, opening a medical school at URI? Are you worried about it?
I guess I would say two things. Great, they're studying it. Second, I would probably put my money elsewhere, but let the study section do their work, because I haven't spent 1 minute thinking about would that be helpful. It's also a very long-term intervention.
Absolutely.
Right.
And I got to tell you, I'm a little more focused on next week, next month, next year, next 2 or 3 years, not. But there's a group looking at it to come up with something.
All right, John Fernandez from Brown Health, Dr. Michael Wagner, Care New England, thanks so much for joining us. We'll see you next week on Newsmakers.